Lovely. I think we are ready to rock and roll. Thank you very much, everybody, for joining CamDocUK on our first ever Zoom webinar, engaging the community, talking about COVID-19. My name is Montio Morgan. I'm an ENT consultant in Basildon in Essex, and I am also the current chairperson of CamDocUK. Today, we have an esteemed lineup of specialists, all CamDocUK members who are ready and waiting to answer your questions, all the burning questions that you have had on your mind since the beginning of this pandemic. So since the end of November 2019, when the first reports came from China, from Wuhan, about this COVID-19, the effects have really spread across the world, and now we know that we are in a pandemic situation. The effects have been devastating, and I would really plead your indulgence, because I would like to start this event by observing a minute of silence to respect all of those across the world and in our Cameroonian community and in our families who have paid the ultimate price by losing their life. I will start that minute of silence now and will indicate when it is over. Thank you. Thank you very much. Thank you very much for that. Now, to start off with, CamDocUK would like to acknowledge the support of all our community members and all the alumni groups, all the cultural groups, all the individual donors, the people who have done fundraising to help CamDocUK raise funds for our project, which is ongoing now, to provide personal protective equipment to frontline workers in Cameroon. As we know, prevention is better than cure. And right from the beginning of this pandemic, we have been engaging with our colleagues at home and across the world, as well as our communities, our family members here in England and in Cameroon, to extend our support and to also provide information and education about the methods that would be the best for preventing this disease. As you will see from our website, this fundraising is ongoing. We have had a few difficulties in getting things going, but we are now looking into strategies to keep our fund our donors up to date with how far we have gone. We believe that it is critical that the money you have placed in our trust be used in the way that is going to benefit the people who most need it. We are accountable to you, our donors, and to the Charity Commission here in the UK, and which is why we are making sure that every single penny that you donate to this drive is used in the right way. So we have partnered with an NGO in Cameroon, Hero Cameroon, but as I said, as our donors, just keep your eye on open, because we will be sending you individualized updates into your inbox as soon as we can. We carried out a survey to find out what are the main burning questions that you have to know about COVID-19 and so on. Amongst the questions that you wanted us to address at this webinar, there were concerns about vaccines and drug trials. There were also issues about mental health in this COVID-19 pandemic, and also about how we support our bereaved and how we support ourselves when we are in this situation. The three top issues, however, that came up were, firstly, debunking myths about COVID-19, which incidentally, we have a video on our CamDocUK website and YouTube channel about that. Disproportionate effect of COVID-19 on our Black and minority ethnic populations, because this is something which is very, very clearly a hot topic on the news just now. And also how we manage the symptoms that we have at home. I would like to again request all attendees to place the questions that they have in the question and answer box at the bottom of the screen, and we will be dealing with this as we go along. We may not be able to answer all the questions, but this is only the beginning, and we are planning to have many more of such community engagement events, and certainly on our website, www.camdocuk.org, we have a facility where you can go on and drop a message, and one of us or some of us will be allocated to answer your questions. You can also see on our YouTube channels and our Facebook, Instagram, and Twitter for lots and lots of educational material. Now, our esteemed panel is made up of specialists in their fields. We will have presentations from Dr Emmanuel Nsutebu, Dr Linda Bello, and Dr Valentine Ngwa. And we also have on our panel Dr Asaah and Dr Elvis Ngassa. I'll introduce them all to you as they come along. And at this point, I would love to introduce our first panelist with his presentation. Dr Emmanuel Nsutebu is the outgoing Vice Chairperson of CamDocUK and is an infectious diseases consultant currently working and he's the chief of the infectious diseases department at Sheikh Shakhbout Medical City in Abu Dhabi. He has led the COVID-19 task force in his hospital for the past 4 months. And he previously used to work at the Liverpool Royal Hospital here in the UK. Dr Nsutebu, we would like you to take on the topic of debunking myths in COVID-19 in the next 10 minutes. Thank you.
Thank you very much, Dr. Morgan. It's great to be able to engage with the rest of our community on about COVID-19. Certainly, I'm sure you all agree with me that the world has changed and changed significantly in the last 4 or 5 months. I think I would also like to start off by saying that most of our community have either had an experience of COVID-19 themselves as an infection, or they now know somebody, friend, family, or colleague who has had COVID-19. And so there's a lot of anxiety. They must have a lot of queries, and there's a lot of controversy as well. So I think this symposium is very, very timely. So I've been asked to talk about the myths with COVID-19, and I want to first talk about our experience in Abu Dhabi and experience of responding to the COVID-19 pandemic in Abu Dhabi. And that I think will bring things to life. And then we'll talk about the scale of the problem globally to put it in perspective. And then we'll then talk about some specific myths. And I guess I have to do all this in 10 minutes, so wish me luck. So the first is our experience in Abu Dhabi. And I think our experience is experience which is similar to experience of people in all parts of the world. And I'm conscious that there are people on this webinar from different parts of the world. So you will recognize either our experience or where you are within your region, your country, your town, your city. So as Dr. Morgan said, I'm based in Abu Dhabi, and we have a large hospital called Sheikh Shakhbout Hospital. And our experience of COVID-19 started in February 2020, when we started having travel-associated cases of COVID-19. People who had traveled to Asia specifically, China, and then returned with infection. And so we're having individual cases of COVID-19. And that tends to be the beginning of the problem in most areas. And then it moved on in March when we started having clusters. And what we mean by clusters is we started having groups of cases of COVID-19. And our first cluster in Abu Dhabi was linked to a cycling event in Abu Dhabi, where we had people from all over the world travel into Abu Dhabi for a cycling event. And specifically, we had a large number of people from Italy that came into Abu Dhabi. And as a result of that, had subsequent infections in Abu Dhabi and then clusters of infection in Abu Dhabi. And so we had to deal with this large number of clusters. And then that moved on in April and May to large-scale community transmission. So we moved from cases to clusters and then community transmission. And what we refer to as the 3 Cs, the 3 phases of COVID-19: cases, clusters, then community transmission. And we had, in April and May, approximately 1,000 to 2,000 new diagnoses of COVID-19 in Abu Dhabi. Most of the cases were amongst laborers, camp workers in Abu Dhabi. Our hospitals were completely full. Emergency department was full and overflowing. Our acute medicine wards were full, and we had to open in our hospital 3 extra wards to look after patients with COVID-19. And most other hospitals, government hospitals in Abu Dhabi, had to do the same. Our intensive care unit also had to expand 3-fold in order to accommodate the number of people who needed critical care as a result of this infection. And our staff had to work over the last 3 months non-stop, no leave, all leave was cancelled, and most of them have been working non-stop, including weekends, in order to deal with this pandemic. So overall, in the UAE, United Arab Emirates, they've had approximately 38,000 patients with COVID-19 reported so far, with about 274 deaths. And we've just now moved in June, where we feel as if we've gone through the surge. At the moment, the number of new diagnoses is coming down. The number of acute admissions is coming down. The number of people in critical care is also coming down. So it feels as if we are just past our surge. And in the UAE and Abu Dhabi, we had more or less a surge and then a flat curve over 2 months. And all that was because of the excellent public health measures that were taken in the UAE. And so this pandemic control is all about public health measures. So mosques were closed, schools were closed since February. There have been travel restrictions for travel out of UAE into UAE, as well as travel restrictions within the UAE. There's been lockdown at certain hours of the day in the UAE. There's been a ban on social gatherings. Mosques have been closed. Shopping malls have been completely closed. And there's been mandatory wearing of masks in public places, including enforcing of social distancing. But most importantly, testing was made available very early. And the UAE has tested more people per million than most countries in the world. So testing has been made readily available from hospitals as well as in the community. People who are positive are admitted to hospital if they are ill, or into hotels and to isolation. And then there's contact tracing of all the contacts. And those that are positive, again, are isolated. So testing, isolation, and contact tracing. And that is what has really helped to keep the curve more or less flat despite the surge. And that, most importantly, is what has saved lives. Whilst the care in hospital is important, the public health measures are much more important. So this pandemic is clear, it is real. Most healthcare systems have struggled with the surge, and it's only by implementing the appropriate public health measures that we can limit the amount of the impact of the illness and the amount of deaths caused by this pandemic. So I hope that brings our experience in Abu Dhabi to life and puts things into perspective. And I'm going to now zoom out and talk about the global perspective. I gave you the figures for the UAE, and we now know that this is the most significant pandemic we've had during this century. Globally, we've had roughly 6.97 million cases so far of COVID-19 globally, and that's resulted in over 400,000 deaths globally reported so far officially. And the epicenter of the outbreak is still, at the moment, is still North America and also South America. It started off in China. It then moved to Europe, which became the epicenter. And then now the epicenter, the main continent affected by the outbreak, is North America. Just to give you a feel, at the moment, there have been 2 million cases diagnosed so far in North America. Russia, 500,000 with 5,500 deaths. And then Brazil, also 600,000 diagnosed so far with COVID-19 with 34,000 deaths. So large amounts of deaths in Brazil. All continents so far have been affected, including our own continent, Africa. And specifically in Cameroon reported up to yesterday 7,392 cases of COVID-19 with approximately 600 new diagnoses a day, and so far 205 deaths. That gives you a perspective of the numbers involved, but one of the myths is, which I'm going to stress on, is these numbers. These numbers are an underestimate. The official numbers are by far an underestimate. Not only an underestimate in terms of reporting, but an underestimate in terms of real cases. The real numbers, as infectious disease and public health physicians we know, are likely to be in the order of 5 to 10 times the numbers that are reported. And that is experienced in the UAE and is also experienced elsewhere. So the numbers are much larger than what is reported officially. So let's then move into some of the specific myths. The first is young people. Can young people acquire this illness? Now, this infection is an infection that can affect all groups of the population. However, those that are most likely to suffer from severe illness and also pass away as a result of the illness, those that are more likely to die, are the older population, especially people over the age of 85, where mortality in that age group is about 15 to 18%. The overall mortality is estimated to be 1 to 3%, and people under the age of 50, less than 1%. But that 1% could be anybody. It could be you, it could be your brother, it could be your sister, it could be your child. So that also has to be put into perspective. It looks small, but it could be any one of us or our relatives. Also, we have to bear in mind that although young people may not develop severe complications and are at low risk of developing severe complications and death, they also result in a lot of transmission. So you may not get it and end up in critical care, but you may pass it to your grandmother, your grandfather, your auntie, your uncle, and they may end up in critical care or die. So it's really important that we take this seriously. It can affect young people, it can transmit it, but they are at a lower risk, but they can also result in severe illness and death in young people. Let's talk about how it is transmitted. And that is also, I think, an area where I'm sure there are a lot of questions and a lot of myths. We'll talk about how it's transmitted, and then the role of people who do not have symptoms, asymptomatic people, and whether they can transmit it. So this infection, the way you get this infection is by being in contact with somebody else who has the infection, who knows they have it or not, and they cough, sneeze, or are speaking to you, and then they produce large moisture particles, which we refer to as droplets. And this directly come in contact with you, your eyes, your nose, your mouth. And as a result of that, you get infected. So it's mainly large droplets, large moisture particles from the mouth, nose, when somebody coughs, sneezes, or speaks, that get into your eyes, nose, or your mouth. Also, you can be in contact with the virus with your hands and then transfer it directly to your eyes, your mouth, your nose. So that is the way you get the infection. And when I refer to as large moisture particles, if somebody is at a distance from you, then they're less likely to pass it on to you because the large moisture particles will drop to the ground if you're not close and will not be in contact with you. We know that those that are most likely to pass the infection are those people who have symptoms because they're coughing, they're sneezing, they're producing a lot of virus as well when they have symptoms. However, studies have shown that 5 to up to 80% of people can have no symptoms or very mild symptoms and may not even notice that they have the infection. And unfortunately, they can also still pass the infection to you. So keeping your distance, whether somebody has symptoms or not, is extremely important. Now, what about the role of smaller moisture particles, or what we refer to as aerosols? That is also important, especially if the person is coughing or is having a procedure in hospital, for example, which generates smaller moisture particles, like nebulizers for somebody who is asthmatic and also has COVID-19. So those small particles can stay in the air for longer, and to prevent transmission, we therefore use a different type of mask to prevent you from inhaling the smaller moisture particles. So having talked about transmission, the role of people who are asymptomatic, no symptom, who can also pass the infection, let's talk about how to prevent it. The first most important measure is keeping your distance. If you keep your distance, you are less likely to get in contact with the droplets from somebody else who has the infection, whether they have symptoms or not. So being at a distance of approximately 2 meters helps. So whether you're at work, at work, and at home, wherever, public places, keeping your distance is a significant intervention to reduce the risk of transmission. Secondly, your hands. One of the means of transmitting it is transferring the virus from your hands to your mouth, nose, your eyes. So you washing your hands frequently and using alcohol gel with at least 60% alcohol to sanitize your hands, to reduce the amount of virus in your hands is an important intervention, and not greeting people with your hands, no hugs, no kisses, so you do not come close. Keeping your distance and also cleaning and sanitizing your hands. And then thirdly, wearing a mask. This is a very controversial issue. It has been controversial, but I think now there is agreement from all professionals, including international bodies like the World Health Organization, that wearing a mask is a significant way of reducing transmission. And so it's now accepted that we should all be wearing masks when we're in contact with other people. Universal masking. And in our hospital in Abu Dhabi, we've actually been doing that since February. Every patient, every member of staff, every visitor wears a mask, and the security staff ensuring that they wear a mask. So wearing a mask is important, and avoiding touching your face and touching the mask, because your hands can become contaminated with the virus if you're touching your face and the mask. So wearing a mask was controversial. It is not anymore. It's a significant tool. And there have been studies, there's a recent study that showed that just by wearing a surgical mask, you reduce the risk of transmission from roughly 17% to 3%. So keep your distance, make sure your hands are clean, and wear a mask and do not touch your face.
Fantastic.
Let's move on to treatment. And that is another area of controversy. And it's even more controversial amongst healthcare workers, and let alone members of the public. However, we know from other coronaviruses, and also with the current COVID-19, that there is currently no known effective cure. So treatment for the mild presentation, the mild illness, is supportive care. Manage the symptoms and give it time for the body to deal with the infection. For the severely ill who have pneumonia and need support, then giving them oxygen, for example, or if their organs fail, so if their lungs fail, kidneys fail, heart fail because of the infection, then admitting them to critical care areas where they can use machines to support these organs and give them time to recover is the main way of treating this infection. However, there is a lot of research going on looking at different specific forms of treatment, which has to do with giving medication to attack the virus itself, antivirals. But also part of the infection and part of the illness is the immune system being overreactive and over-responsive and causing inflammation in organs such as the lungs, and the person suffering as a result of the intense inflammation in the lungs due to its immune system's response to the infection. So there's also treatment that's being looked into to try and dampen that immune response and see whether that will help improve the outcome for the patients. Specifically, one of the drugs which is quite controversial and quite topical is hydroxychloroquine. And so I think one of the myths is, does hydroxychloroquine work or not? It's simple, it's cheap, we've used it for malaria, so why not? Why not use it? The reason why it's controversial is because there's data from laboratory data, from test tube data, where we've seen that hydroxychloroquine can potentially have an effect on the virus and kill the virus in the laboratory. However, the concentrations of hydroxychloroquine that we use in the test tubes are quite high, very different from the concentration of hydroxychloroquine that would be in the body of the patient, because at that doses, they will cause significant side effects. And the side effect mainly is heart side effects. It can cause an irregular heart rate and also death from high doses of hydroxychloroquine. So this has been investigated and it's been controversial because there have been different studies, one of which is a study produced, which was published in the Lancet, most people have heard about, which was finally retracted because of the validity of some of the data that they use. However, we know from a very good study that hydroxychloroquine doesn't seem to help people who have been exposed to the virus and is given as a means of prevention. We also know that people who have moderate or severe disease from good randomized control trials, good, well-performed studies, that it doesn't seem to help people with moderate or severe disease. So it doesn't seem to prevent, is what we know at the moment. It doesn't seem to help moderate and severe. And there's still an argument that maybe it may help those in the middle, people with mild disease, to help them to progress. But scientifically, it doesn't really add up if it doesn't help people to prevent illness and doesn't help moderate or severe. It's unlikely that in the middle it's going to help people with mild disease. However, there's still ongoing research studies that will help answer this question, one of which is a study which is being done by the World Health Organization called the Solidarity Trial. And we're hoping that that will be the final trial that will tell us whether hydroxychloroquine will work or not. So at the moment, countries, doctors, physicians are still using it if they think that the benefit outweighs the risk, but we simply do not know for sure. And the evidence so far that is probably unlikely to be of benefit, but some people may still want to use it. Okay. Now let's finish off by talking about whether we can actually eradicate this virus. Can we actually cure and eradicate this virus, and will we ever get rid of it? My view is the world has changed. It is unlikely that we are going to get rid of COVID-19 without a vaccine. The vaccine is most likely to be available, we think, next year, not this year, because of the length of time it takes to produce an effective vaccine. Although there is hope because there are a number of vaccines that are in development and progressing very fast. So living with COVID-19, I think, is going to be our new norm. There have been very few countries that have eradicated COVID-19, such as New Zealand, where they haven't had any reported cases, but they've also stopped travel. And when they open up travel, you're sure to expect that they will have cases. So it's unlikely that we're going to get rid of it. I think for those that have gone through the surge, it's likely that COVID-19 will become endemic, which will mean we'll be living with it, just like the flu, until we have a vaccine which we all can take and which is effective. So we've got to maintain all the measures of social distancing, avoiding public gatherings, keeping our hands clean, wearing a mask. And we have to look at our work environment and our interactions with friends and community in such a way that will reduce the risk for each other. Because even if you've had COVID-19, it doesn't mean you are immune. We don't know yet whether you can still get it again. And so for now, everybody still needs to continue with the same measures, whether you've had it or not, or whether you think you're through a surge or not. The world has changed and there is a new norm, which is living with COVID-19. I'll stop there. Thank you very much.
Well, thank you very, very much, Dr. Nsutebu. That has been a real wonderful roundup of the myths and current knowledge about COVID-19 as we've got it as we've got it now. While we've been ongoing, I must say that there's been a brisk question and answer session going on in the question and answer box. I will advise people who have questions not to raise their hands as they would normally do in the Zoom, but to put their questions in the Q&A box, and those will be addressed. I would also just like to take this opportunity to thank everybody, all of our attendees, and to apologize most profusely for the technical glitch that we had at the beginning. I'll just round up in saying that, just to say that we are aware that a lot of you were waiting for us to show up somewhere else in another Zoom meeting, but hopefully everybody has transferred over now. Just to let you know that this this event is recorded, and we will be giving you the link so that you can watch it in its totality. It would be remiss of me if I did not just let you know that at the beginning of our event, we had a 1-minute silence to respect the lives of those who have been lost across the globe, and especially within our families, to COVID-19. And also that I made a comment, or not even a comment, a gratitude plea to all of those who have donated, all of our donors who have donated cash, and who have donated their time, and who have supported and continue to support us in our project to raise funds for personal protective equipment for our colleagues in Cameroon. Again, thank you very much, Dr. Nsutebu. There are questions coming in the question and answer session, in the question and answer box. Some of them are already being answered, and I would like to acknowledge Dr. Brown-Hilda Santo, who has joined in from the United States. She's not a CamDocUK member, but has provided a really good answer to some questions that are going on, ongoing. We will be answering as many of those questions as we can. One question here that I think we might pick up, Emmanuel, just to you, is do you feel that sub-Saharan Africa is past this peak of infection, or can we expect the next epicenter to be in Africa? Just very briefly.
Yeah, very briefly, I think Africa has not peaked. The reports that you see formally on the websites are, as I alluded to, are underestimates, under-reporting, but significant under-testing. And so the real figures are likely to be 5 to 10-fold that, and probably more. And I think there's a lot of illness that is undiagnosed. Mm-hmm. Mm-hmm. I think Africa, the epicenter moved from Europe, from Asia, Middle East, Europe, and America, and Africa. And I think most countries in Africa are still in the cluster phase and moving into community transmission. So specifically, for example, in Cameroon, we know that Douala is currently within Cameroon, the epicenter, as well as Yaoundé, but there are cases also being identified in other parts of the country. So in the next month, what we expect is a move into the community transmission phase with cases all over the country. And most parts of Africa have not yet done that. Mm-hmm. So I think there's still room, we still expect a large increase in numbers.
Okay.
I think in terms of mortality, we will not expect seeing as much deaths in Africa, we think. Part of it is because of reporting and people not knowing the cause of death. Mm-hmm. But we also have a relatively younger population in Africa. And the impact on Africa in terms of death is likely to be less just because of the younger population.
Okay. Thank you. Thank you very much, Dr. Nsutebu. I'll just address a concern from somebody who has put it in the question and answer. Obviously, we started a little bit late and there was some technical glitches. So we are hoping that we will be able to continue till about at least 7:30 and just after 7:30. So we will hopefully be able to get our program all sorted. It's my immediate delight to introduce Dr. Linda Bello. Dr. Bello is a GP who works in London in the Clapham family practice, so GP or family practitioner. She is the children's safeguarding lead for her general practice and is the chairperson elect of CamDocUK, and in late terms that means she's taking over from me later on this month. So Dr. Bello, your brief is to talk about how people can manage symptoms at home in 10 minutes.
Okay, thank you, Dr. Morgan, and may I just say thank you to all of our attendees today. You're here in your numbers. We're grateful. And yeah, it's my pleasure to talk to you about, how you would manage symptoms of coronavirus at home. So if we start from the beginning and what my colleague has just been talking to you about very eloquently, is that there's currently not a cure for COVID-19. We don't have a vaccine, maybe hopefully next year. So the aim of treatment or management is to reduce your symptoms until you have recovered. And we know, thankfully, that most people, so around 80%, will have an asymptomatic illness, so no symptoms at all, or a mild infection which can be treated at home. So my talk is based on these, is really geared towards these 80% of people. And of course, if you're having symptoms of COVID-19, you should be self-isolating for 1 week until you've recovered. I should just add, as Dr. Nsutebu touched on, that 1 in 5 people who contract COVID-19 will require hospital care, and around 15% of the total cases will experience a severe infection requiring oxygen to help with their symptoms, and also 5% would experience a critical infection. In that case, they will require ventilation, so which is where we put a tube in to help people breathe. And as was touched on as well, that those at higher risk of severe or critical infection usually include those who are older and those who have underlying health conditions. So what are the symptoms of coronavirus? I'm sure we've all heard of these, but I'll start with the 3 main ones, which are the high temperature. So a temperature above 37.8 degrees Celsius, or if you don't have a thermometer, if your skin feels warm to touch, specifically that on your chest wall, so if that feels hot, then you're probably having a temperature. A new continuous cough. So a new continuous cough, and that's, not just coughing for a few seconds, a continuous cough for up to a few minutes. And the third symptom, which was just added recently, was a loss or change to your sense of taste or smell. And in the UK and nearly everywhere else in the world, you would be told to self-isolate if you had those 3 main symptoms. So self-isolate for 7 days, and if you live in a household, your people in your household will be self-isolating for 14 days unless they had symptoms. So that's very important. That's the official government guidance in the UK, also from Public Health England. Now, we know that people can get other symptoms. So, fatigue being one of them, headaches, sore throat, sort of general aches and pains, but those are not the 3 main ones which require you to self-isolate. So I shall just talk a little bit about some of the symptoms I've mentioned and how you can manage these at home. So the first one is treating a high temperature. What would you do for that? So most of us know if you have a high temperature, it can help to have lots of rest. So rest is always helpful. Drink plenty of fluids, especially water, to avoid dehydration. So you want to drink enough so that your urine is light yellow and clear. And usually that should be at least 2 liters of water or fluids a day. You can take paracetamol or ibuprofen if you're feeling uncomfortable. And I think a lot of people will be thinking, well, ibuprofen, is that safe to take, with coronavirus? Yes, there were some reports that said that anti-inflammatories such as ibuprofen could make coronavirus worse. However, the Commission of Human Medicines has now confirmed that there's no evidence that if you use ibuprofen to control a high temperature, there's no evidence that it will make coronavirus worse. So you can use it. However, I usually tell my patients, and I'll tell you all here, that, try paracetamol first if you can, because it has fewer side effects than ibuprofen, and it's usually quite a safe choice for most people. And the most important thing is if you've bought these over the counter without a prescription, then you must follow the instructions that come with the medicine. So that's about fever. So what would you do with a cough? So if you have a cough, it's best to avoid lying on your back. So perhaps just lie on your side or sit upright instead. And to ease the cough, you can use a teaspoon of honey. But very, very important, do not give honey to babies under 12 months. And the reason is that some of the honey preparations contain bacteria that can produce toxins in babies and can cause a very serious illness called infant botulism. So please don't use honey in babies under 12 months old. If you find that despite all your natural remedies and things at home that the cough is not going away, you could contact your pharmacist to see if there's other treatments that can be given over the counter. So there's cough suppressants and things like that. But obviously, if you're self-isolating, you wouldn't want to be leaving the house to go and ask your pharmacist that. So you could contact your pharmacist online or maybe ring them. And failing that, you could always contact your GP. There's always helpful advice online as well through 111. So following from the cough, you might start feeling breathless. And some top tips to help with breathlessness is that if you're feeling breathless, you might want to keep the room cool. Try to turn your heating down if it's on. Try to open a window, but don't use a fan because that may spread the virus. You could also try to breathe very slowly through your nose and out through your mouth with your lips together as if you're going to gently blow out a candle. Sit upright in your chair. Relax your shoulders so that you're not hunched. Lean forward slightly, and you can support yourself by putting your hands on your knees or something like a chair. So that will help. But really, the most important thing is to, it's a bit counterintuitive because you're breathless and you're worried, and the natural thing is you want to panic, but try not to panic because it can make things worse. Most importantly, feeling breathless can be a more serious sign of coronavirus infection. So if you do feel that the breathing is getting worse, despite all those techniques I've just given you, then you must get urgent medical advice. So in the UK, it would be calling the NHS 111. You can try the advice service, which is available online, or you can ring them. If you feel that you've not been able to get through to them, or you've not been able to get information on there, your GPs, we're always here, so you can ring your GP and speak to a GP. In Cameroon, you can call 150. And then I would like to also talk about, I've spoken about cough and difficulty breathing, about antibiotics. Because of course, sometimes, some patients have had a cough for such a long time, and you may find that your doctor might give you an antibiotic. I must stress that the antibiotic is not being used to treat the virus, because antibiotics are not going to cure coronavirus. A lot of the times we're prescribing this to treat what we assume to be a superadded infection, which is caused by bacteria. So that's why you might find that your doctor might give you amoxicillin, azithromycin, doxycycline, antibiotics like that. If you have antibiotics lying around at home, please do not take them, because one, you don't know, you should never take antibiotics that haven't been prescribed for the condition that you're using it for. So please don't do that. Always ask for advice about that. Now, other things that can be really helpful. So rest, which I've alluded to, and sleep. So sleep is really essential in sort of building up your energy again, because you'll be feeling quite lethargic, and fixing and repairing your body when you're unwell. So when you do have a virus, your body's immune response sort of tries to make you more sleepy so that it can, and tired, so that it can do everything it can to fight the infection and promote recovery so you can get well. If you refuse and to give in to the urge to rest and nap, it could prolong your illness, not least because your body also needs to break out in a fever in order to try to fight the virus. And we know that fevers most often occur during sleep. Don't do any vigorous exercise because, but if you can, just try and do some light activity. So walk around, because again, this will help you to sleep when you need to. So the other sort of symptom that I mentioned was this loss of smell and taste. Now, unfortunately, there's not much that can be done about that when it's caused by the coronavirus. We know that it can take weeks or up to months for the sense of smell to come back. But the good news is that recently there's two websites. So one is called the Absent website, so Absent, but with a C after the S. And there's another website called Fifth Sense, which give you some smell training. So, if you've lost your smell, it's been a few weeks, they give you tips of how to kind of, basically train your nose how to smell again. So, have a look at that, and perhaps our co-moderators could put that in the chat box so people will be able to see that. So when should you see a doctor? So I've thought about 5 sort of key reasons that you should, so you've been managing things at home. You think, gosh, I'm not feeling better. It's been a week, things are not getting better. So first things first, the breathlessness, which I've spoken about. So you're becoming rapidly more breathless, even when you're sitting down and doing nothing. That's not a good sign. You cannot manage basic things such as showering, eating, watching the television, or even just reading. You start becoming confused. You cannot speak in whole sentences without taking extra breaths. And if you are in the UK, one of the 1.5 million people who have been advised to shield. So those that are shielding are usually those that have really serious underlying medical conditions. So you should really be speaking to your GP. So to summarize, as I've said, 80% of us will be able, will have an asymptomatic or mild illness, which can be managed at home with the simple techniques and tips that I've just mentioned. But if you, at any point, you feel that your illness is worsening, you feel that things are not improving after 7 days, you must seek medical attention as soon as possible. If it's not an emergency, NHS 111 online, 111 in Cameroon 150. No internet access, obviously you're going to be calling 111 anyway. And if it's an emergency, you're going to call the ambulance on 999, but you need to tell the call handler that you've got coronavirus. And that's my lot. Thank you very much.
Thank you very much, Dr. Bello. That has really been a whistle-stop round of how to manage coronavirus at home. There's been lots and lots of questions in the question and answer box, which have been answered as we are going along. I will tie these up towards the end, just so that we get enough time for people to get the story from the horse's mouth, if you like, to put it that way. From the point of view of managing symptoms at home, people have a lot of concerns, and I'm sure that these answers, this talk that you've given has gone a long way to respond to these concerns. There have been a lot of well, I don't want to use the word concerns again because it sounds so pathetic. I mean, there's fear in the community. People are worried, they're scared. They turn on the TV and they find all these reports about people who look like me, who look like yourselves, and who are more at risk of being dying from coronavirus. Is this coronavirus racist? Is it targeting Black and minority ethnic people? Why are we dying more from this? Dr. Valentine Ngwa is a consultant. He's a consultant in acute and elderly medicine. He's a consultant physician in acute and elderly medicine at the Mid Yorkshire Hospital, NHS Trust in Wakefield. He's also a frontline physician on COVID-19, and Dr. Ngwa is a social gerontologist with an interest in aging and social determinants of health. Now, there's no better person to really talk to us about this disproportionate impact on our Black and minority ethnic population than Dr. Ngwa, and it is my pleasure to welcome him as a panelist. I will also just reassure you that all your questions are being picked up and they will be dealt with. We have Dr. Asaah, as I said, and he has already got some questions that have been allocated to him, as well as Dr. Elvis Ngassa, who is a panelist and will be dealing with these questions as they come as we move on in the event. Dr. Ngwa.
Thank you very much, Dr. Morgan. Good evening, ladies and gentlemen. As you rightly said, there's been a disproportionate death in our Black, Asian, minority ethnic group, which is nothing new. We've had that in the news and the papers, and of course, is bringing a lot of fear, as you rightly said, in this population. And there had been a lot of calls on the government to see into this and provide solutions, and the government mandated Public Health England to do that study and bring out solutions to this problem and how we can mitigate this. Public Health England came out with their report last Tuesday, as we all know, which they called it the disparities in the risk and outcomes from COVID-19. It didn't go as far as we had expected. We expected to give us some solutions on where we could take it and run. So my talk today will be to try and talk about what Public Health England came out with, to try and go behind some of the reasons or associations why we have this, which is mitigating this scenario, and conclude by trying to provide some solutions, if I may. So Public Health England did say, and I'll start there, they did acknowledge that there was a high rate of infection in the BAME population that we all know the data has been out there. They did say part of the reason is because a large workforce, people forward. So a large of these have a high rate of exposure to the virus because they work in professions where they had to deal with the community. I'm talking about drivers, taxi drivers, bus drivers. I'm talking about shop workers and cleaners and builders at lower levels. And of course, healthcare professionals as well. Well, we know this before from all the surveys we've had in the UK about this. We've had the labor survey, we've had the household survey, so we knew all this. Now, one thing they also mentioned was the fact that the high rate of overcrowding in some of the households of the BAME population. Again, we knew all this because we've had these surveys before. In fact, the survey that we had before from housing survey did say the Bangladeshi population have about 40% of the living overcrowded housing as opposed to 2% of white houses. And the black houses about 9%. So we knew all this. And because this is a droplet infection, as my colleague, Dr. Nsutebu, had told us, it is likely that the closer you are to somebody, the chance of getting the virus is there. So social distancing is a bit difficult in that situation. This household also have a high tendency of multi-family and multi-generational households. And as you mentioned, the kids can easily pass that over to the older ones. We saw that the first wave in Italy, that's what happened when the schools closed and the kids went home to their grandparents and infected them. Unfortunately as well, the BAME population are the highest ones to live in deprived areas. And by that, they face all the ills of deprived areas. We know those areas have high crime rate. We know there's high rate of comorbidities in those areas. There's high rate of unemployment. The data shows about 9% of Black people are unemployed in the UK, or those that are employed are underemployed as well. So all those comes with your problem. These are socioeconomic problems that we all know about, and of course, which have been associated with the increased rate of COVID-19. But this report says something very important that I want to dwell on. They did look at 10,000 patients in the intensive care unit. And when they could adjust for age, we know the older you are, the more chance of you dying. They could adjust for sex, we know the males are dying more than the females. And they could adjust for comorbidities. So they could adjust for age, sex, and comorbidities. They found no difference in the mortality between the ethnic groups. What that means, therefore, is if we take age and sex apart, the comorbidities is the game changer. And by comorbidities, they meant hypertension, diabetes, chronic kidney disease, COPD, heart diseases. We've always known that these are higher in the BAME population. We know that the Blacks have higher chances of having heart hypertension. The Southeast Asians have higher type 2 diabetes. And we also know that it all leads to worse outcome in this population for 5 various reasons. And so the comorbidity is something we can talk at length at. But because of time constraint, and if I may, I want to dwell on 2 aspects of it, which I think are quite important. The first is the vitamin D status, and the second is inflammation. Now, why vitamin D status? There are studies across the board that have shown before that all these comorbidities are linked to vitamin D deficiency. Whether it's a cause or an effect is an argument for a different time. And so patients with hypertension, type 2 diabetes, patients with CKD have higher chance of vitamin D deficiency. And I want to focus on vitamin D because it's bringing a lot of attention at the moment. We know it is an immune modulator of vitamin D. We know from studies before in the past that patients who are deficient in vitamin D have higher chance of getting respiratory infections. In fact, there was some study done in Scotland in 2015 when they noticed that patients from Black minority ethnic groups had more severe disease when they have vitamin D deficiency than their white counterparts. And that there was a communique now put out by NHS Scotland together with University of Aberdeen, Edinburgh, and Cambridge, advising that all BAME populations should be checked for vitamin D deficiency and corrected, because there was a link there between that and the flu virus. Now, we also know that vitamin D has been shown to have worse outcomes in various vitamin D deficiency in various populations. This was studied in Italy, Spain, Denmark, and Sweden. Now, Denmark and Sweden being countries that fortified their diet with vitamin D, and they had low mortality because the prevalence of deficiency of vitamin D was lower as compared to Italy and Spain. And that was a very good study that was done by the team in Ireland, and which all gives this correlation. We know correlation doesn't mean association, doesn't mean causation. But if I may, I want to draw our attention to another study in Sweden, where this time around, this population didn't have comorbidities, so they didn't have much hypertension or diabetes, but they were vitamin D deficient, and that was the Somali population in Sweden, which make up less than 1% of the population of Stockholm, but they made up about 40% of the severe disease and mortality of COVID. And that was linked to the fact that they had a high level of vitamin D deficiency because of the darker skin. They dress full gear, and they rarely go out, particularly they are women. So vitamin D deficiency is a very important component that has been associated with COVID severity. And I'm glad to know that some trusts in Wales have now started giving vitamin D replacement to their BAME staff in an effort to protect them. The next thing I want to talk about is inflammation as pertains to comorbidities. We now know that inflammation is at the center of most chronic diseases. So type 2 diabetes is an autoinflammatory disease, depression is an autoinflammatory disease, stroke it is. Now, and there are a whole lot of things that can render somebody to be on high level of inflammation. And the diet is one of them. And we know there's something called the dietary inflammatory index, and which if you look at that index, the thing at the top are the refined carbohydrates, animal proteins, and fats. We also know that stress level. Most of our BAME community, as we said before, live in deprived areas. They're unemployed and underemployed. We know some people go to work and the workplace looks like a battlefield where there's a lot of discrimination, racism in the society. All those ramps up their stress level, increases their inflammation, and reduces their immunity. And we also know that a lot of our BAME colleagues work in night shift jobs where they work shift patterns. And it has been proven time and time again that poor sleep leads to increased inflammation and reduced immunity. That's why shift workers have a higher chance of type 2 diabetes and dying younger. So all this put in place are actually some of the reasons why we're having chronic diseases in our community and why it's increasing the mortality from COVID-19. But that said, there are things that we don't know yet, which they've been written about. We need to take it forward and look into it. And the most important of them is our own attitude to health. How do our people understand healthcare? How do they embrace healthcare? Study came out not long ago showing that Black people have 66% chance of defaulting from their pap smear, as opposed to about 11% from the whites, which means that they don't take up the healthcare services quite well. Now, you could ask what the reason is. Is it because of their belief system? Is it because of their religious belief? We have heard pastors say in churches to people, pray and don't believe what the doctor tells you. Or is it because of their distrust for the health service? There's lots and lots of papers showing that quite a few BAME people don't go to hospital because they don't trust the health service, because they don't listen to them and they don't take their symptoms serious. Now, we know all these things are tied up to this mortality, and we have a lot of the words. It is time we start putting the numbers to the words by getting robust data that we can now shove in the eyes of the government and say, something has to change, policy has to change. It wouldn't just be in changing by us giving one tablet to somebody. And so, Mrs. Chair, if I may, you've noticed that I have spoken on medicine, on nutrition and diet, on social aspect. The only way we could start mitigating this is to involve all our experts in these fields, our dietitian, nutritionists, our social scientists, our behavioral scientists, and of course our community leaders and everybody else. And that's the way. If we do not do that, and I'll just conclude by saying, if we do not do that, we will be forced to start hearing of the other narrative. Because if you read some papers, and outside talking that the reason why the BAME are having high mortality is because they have an inherent weakness in their system that they can't stand the infection. Of course, we know that's not true. Otherwise, Africa will be all dead at the moment, but it's the reverse. And there's now coming to the talk of being responsible. We know if you go across the pond in America, when COVID started, in some quarters, it was more of a public health issue. But when they started finding out there were more Blacks dying, it now started becoming an issue of irresponsibility. So if we do not engage and put the right words or the right numbers there, we'll be forced to deal with the narrative from the other side. I'll rest there. Thank you so much.
Thank you really very much. I mean, it's fascinating. Every time I listen to you talk, I am spellbound because you have such a massive know-how and knowledge about all these things that are going on. The question and chat, question and answer area has been absolutely brisk. CamDocUK members have been answering all your questions. I'll just pick out a few. The main ones that are coming up really are, because a lot of the questions have been answered already as we speak. But the main ones that haven't been answered so far are those to do with the vexed issue of traditional medicine, how drug trials, what is happening in Africa where we cannot really do social distancing. So should we be scared about what's going to happen in Cameroon? We have quite a few questions that have been directed to Dr. Asaah, who is standing by to answer all these questions, and he will put them together. Dr. Nkohkwo is a clinical scientist and a public health consultant. For a long time, he worked in acute hospitals, and more recently, he has moved to work in the community to prevent patients having to be hospitalized. And he is the managing director of a team of Team Carita. Prior to this, he was the CEO of the Sickle Cell Society, and he is very, very active as the chair of our international community here at CamDocUK. On top of this, Fouassé Fontem, as we call him, is a Bangwa chief with all the protocol that is required. I invite Fouassé Fontem to talk about, to answer the questions that have been coming up regarding traditional medicine and drug trials in Africa. Thank you.
Thank you, Dr. Morgan. Thank you, everyone. Can you hear me? Can Dr. Morgan hear me? Okay. Thank you so much. It's been wonderful so far listening to all your physicians speak. I say physician just to let people understand that, as Dr. Morgan said, I'm actually a clinical scientist. I am, what does that mean? I'm excited to be at that interface where you have discovery and invention being looked at so that they get it ready for the physicians to use it to treat you, the public. So in other words, I work at that interface where we ask questions to enable physicians to be able to use them as invention as medicine to treat people. Now, there are a number of questions have come through. Typically, I think Marie-Claire Kofi wanted to know specifically that the regulatory arrangement that is in Cameroon, and also if not, then why we as CamDocUK are challenging number of medications that are emerging in the public. I think Robert also went further to actually name specific ones like the COVID organics, as well as the one that is presently, COVID organics is the one, those who are in the social media or follow the story will be the one that is so far presented from Madagascar. There is COVID, there is the other one that is now the hot topic in Cameroon, promoted by Archbishop of Douala, Bishop Cleda. So like I started by saying, I'm not speaking for Cameroon government. I don't think CamDoc is speaking for Cameroon government either. But what I'm going to offer here as an answer is based on the experience I've had over the 25 years first as a student in the Cameroon health system. While I was training in Manchester, I went to Cameroon for a number of stage, as they call it in Cameroon, placement, and also latterly of consultancy work that I've done in the Cameroon system, which essentially pulling all this together, why I played the role of the head of the international committee at CamDocUK. Now, I'm saying this because through this interaction, we know that in Cameroon, medications are actually being licensed through an arrangement from the Department of Pharmacy at the Ministry of Public Health. The Ministry of Public Health is a directorate for pharmacy and laboratory that actually organizes the issue of how medicines are actually licensed or even brought into the Cameroon system. There is also, the government also has the Institute of Medicinal Research. But be that as may, I started by saying as a clinical scientist, what matters for this particular issue is, what the key question here is, how do you tell confidence in a particular medication that's being presented to the public? This is where CamDoc, the position statement that I think Marie-Claire made reference to, we had to put out a position statement in our own way to say, here is what we think in terms of there is a medication like we've heard about COVID organics, we've heard about fagaricin, another one in Gabon, and now we heard about the one being presented, promoted by Bishop Cleda. How do you know? How do you tell? How do you gain confidence in this particular medication? This is something that could take a whole seminar, but let me just zero down to especially confidence means you want to find out if that medication is effective. Is it effective? Does it do what it says it will do? The second thing is it safe? Now, the reason we're saying this is that in terms of, I should have also added not just effective, but safety, but I've also mentioned whether it's specific. We know in Cameroon, you find at certain points, people come with those, for example, traditional herbalists, you don't know whether what they have in their jar is the same thing in the same jar that they are using to treat orange, they claim as cure for all sorts of conditions. So that's a whole big topic, but the key issue here is evidence of effectiveness, evidence of safety, evidence of, so that position statement which we presented to you was essentially help in our own way to give guidance as to say that if you take the case of COVID organics, how do you know that it's actually effective? How do you know that it is safe? Because as we stated in our article there, even water that you drink can actually be a poison. It just depends on the dose, how much of it that you take and what you actually take it for. We've had the case of a hydroxychloroquine, but let me not divert. Let me focus on just this one that I've been mentioned. So in other words, in that article which you presented, we try to give some sort of a guidelines as for you to understand that that effectiveness and that safety, for you to arrive at that decision, clinical science has actually got a convention, an agreed protocol, a time-tested protocol, which means that there has to be a governance arrangement, a governance team that supervises that the testing of that particular medication, that particular intervention, the testing, to ensure that that testing actually does what it says it does. That team that is so that governance arrangement is what we explained in that document, as you need to have a trial team that will actually be hands-on doing the testing itself. You need to have also a supervisory team that looks at the ethical issues, because if you want to, if you want the ethical issues we're looking at, for you to get involved in this, and for that particular drug to have arrived at that acceptance, there has to be consent issues as well that will have to come in. I mean, it's a whole big topic. Specifically for the time that I've got, I want to say that what we want to see for evidence is, has COVID organics, has anybody seen the evidence that it actually does what it says it does? And when we say, have anybody seen this evidence has to come through in a particular way in which science over the years, over the generation, have agreed that this is how evidence is accepted. That document tells you about levels of evidence. In other words, has this thing been put through a randomized in such a way that the evidence, there's no bias in it? So these are some of the aspects that we expect to guide you through. And then the other part now, for want of time, the other one is about the regulatory arrangement that there is in Cameroon. Now, like I started by saying that, not speaking for Cameroon government, but through our interaction, number of us as CamDocUK members, we know that the arrangement in Cameroon, the Department of Pharmacy and Laboratory in the Ministry of Public Health actually addresses the licensing process. There is obviously, therefore, an arrangement where drugs are actually being licensed to use in Cameroon. But what has come across so far is that there is loss of confidence. There is lack of confidence. Some people may have seen on TV where even the scientists who try to promote some of the new interventions, some of the new drugs, some of the clinical trials have been challenged by the public. And there was a very worrying case where a scientist was being asked if she could actually vaccinate her own children before they accept. So what I'm saying here is that there is a total loss of confidence. So this brings us now to the second point, loss of confidence in the regulatory process, which I mentioned before, but that is for Cameroon government to answer. But what we're saying is, speaking on behalf of the public, we are recommending a total revamp of this whatever system they have now. We are recommending a total revamp towards what? We are saying that the new dispensations should be such that they, at the end, there will be some legitimacy, there will be some credibility from the general public. And how does that credibility come about? We were saying that there should be some sort of advocate, surrogate. It will start by surrogate advocate because you need, it's a very complicated process. So we need surrogate advocates in the sense that these are people who understand the complexity of this, who will be chosen by the public themselves to represent them on those panels. So that's why in that article we made mention about a national center. We mentioned a national board for medical development, which we call CEMED. So we suggested that whatever exists now in Cameroon has lost legitimacy. So we are recommending that we regain legitimacy by the government revamping the system and making sure that the public at large has a say in that board and in that arrangement at the highest possible level. And this is what we're calling, we're suggesting about CEMED. So I have mentioned the fact that I mentioned the fact that that particular, one of the reasons why we have the skepticism about COVID organics, skepticism about the medication promoted by the Archbishop, skepticism about even clinical trials that are through which medications will emerge from this thing. The reason for skepticism is coming from the fact that the regulatory environment itself is questionable, and we are also at the same time supporting you, the general public, on how science actually arrived at giving confidence in a new drug. How does a drug arrive at this issue to do with the evidence? You have to evidence that it is safe. You have to evidence that it is effective. You have to evidence so the dose at which it's working. You have to evidence the specificity. The fact that you must not, one concoction should not therefore be used for a whole range of things, because that's not how medicine works, by identifying the active ingredient and making sure that active ingredient is what is effective and is safe. And unless the active ingredient is effective for a number of conditions, you should not be using the same one for a range of things. We've had the case of where they were talking about the hydroxychloroquine. It was licensed for malaria, but it's being tried for something else. And I want to finish one key burning issue relating to this, traditional remedy. The key issue here is that we recognize we don't condemn traditional practitioners. We should quickly make it clear. We do not condemn traditional practitioners, but at the same time, we do not sit here to endorse them. We are not endorsing traditional practitioners. What we recognize, though, is the fact that, as we know, 40% of medicine that we use today started from plants. And herbalists actually have a lot of expertise in this area, which we see, rather than pushing them away, we need to effectively bring them in a formal arrangement. So we see traditional herbalists as a potential that needs to be harnessed in a formal, through this conventional process, which I was explaining earlier. So we are saying that rather than pushing the herbalists away, we need to look at this, maybe this new board we're talking about might look at an arrangement where it will also give them some I emphasize pre-license, not licensing their products. For example, what Archbishop Teda is saying now, what the Madagascar is calling as COVID organics, will serve as candidate medicine. These candidate drugs will then be put through the conventional process to establish that they are effective, to establish that they are safe. So we are saying that traditional remedies, traditional herbalists could serve for a very important source for candidate medicine. But we are not endorsing what they're doing. We're saying that they need to be brought within a formal framework. I think, given the time that I've got, this is what I say for now. But again, those who are interested to discuss a little bit further, I'm sure through CamDoc, we will then be able to address this, even through direct correspondence, where you could give you more information. All what I've been speaking here is clearly evident. We can give you references so that you can actually look it further and then have further discussion with us offline. Thank you very much.
Thank you so much. Thank you. I mean, if we wanted to stay over the whole night, we could stay here speaking about COVID-19. Unfortunately, we only have a limited amount of time. A lot of questions have been coming in about the Monsignor Cleda. Is there any evidence that they've caused harm? Well, the absence of harm does not mean that there is the absence of evidence of harm does not mean that the harm has not been evidenced. So we need to be sure that what we are giving to people is safe, that it is the frequency of administration, that we can replicate the results of the medication. So that's all that CamDocUK is saying. And we can continue with this discussion more and more. Dr. Elvis Ngassa is our final panelist, and I just wanted to ask him, Elvis is actually a transplant surgeon in London, and during the epidemic, or during the pandemic, because regular operations were put on hold, Elvis donated his time and energy to go and work and support the intensive care unit patients in his hospital. And as such, he has actually seen very, very close up those patients who go past the level that Dr. Bello was talking about, that we could manage at home, and had to be hospitalized. So I just wanted to put a question to Elvis, just to reassure our attendees about that spectrum of the illness, and what actually you have been seeing in the hospital. Elvis.
Thank you, Dr. Montio Morgan. Thanks. I also want to thank everyone for following us, for having registered to this webinar. Yes, most of you will be asking yourself, what has a transplant surgeon or a surgeon as a whole got to do with COVID? We all know it's a medical condition which doesn't require any surgery. But as you rightly put it, we were redeployed to ITU to help our colleagues. The workload was so much so that they couldn't bear it alone. So what we were doing exactly was we were involved with inserting all sorts of lines. These patients, you cannot manage them without those lines. Some of them needed dialysis, so we would insert them vascats. We insert central lines. You need central lines for monitoring, and also to administrate IV drugs. So our main role was that, but I also took advantage of my presence on ITU to see a bit, to learn a bit of what intensivists were doing. And it was really a great experience. It was very emotional, because as you know, 80% of patients, they don't require to go to hospital. Among the 20% who end up in hospital, just 1 out of 6 end up on ITU. So on ITU, you've got the critically ill patients. So we were dealing with, the worst scenario possible. And unfortunately, at the peak of this pandemic here in London, you had about 50% of the patients who went to ITU died, unfortunately. So it was really a difficult atmosphere. I saw many colleagues breaking down. But the good thing was that the solidarity among us was strong. The friendship, people you've never worked before with, people from different teams all working together. And one strange conclusion which we all made, unbelievable, was that we felt safer in hospital, and we felt we felt safer in hospital than at home watching the TV. When we went back home and we watched the news, it looked so much more dramatic than what we experienced on our daily activities. So it was a nice experience for me.
Thank you very much for that very personal report, Dr. Ngassa. As we've said, prevention is better than cure. We need to reassure our people that 80%, as Dr. Bello said, are not going to have a very bad illness and will not need to be hospitalized. However, we need to encourage our populations to be more open to seek medical attention, and so that we can give them the information that they require. Dr. Nsutebu gave us a really good roundup, and he has been answering questions live on the chat box, and there's still questions coming in. I think what we will have to do at this point is, unfortunately, we have to close it here. The questions about modern scientific procedures, we definitely picked up that question, Mr. Kofi, about 70% of African population which has relied on traditional remedies so far without the need for modern scientific strategies. Is this something that we can comment about? As Foisse Fontaine did say, we're quite happy to take that on and to address these questions either at a later date or on our website directly in the questions and answers. Now, as I said, unless there was any burning comments from the panelists to round up, I'm afraid that we have come to the end of our webinar, which I am really, really pleased to say we've had more than 100 attendees, lots and lots of questions. Hello.
Hello. Just there was a really important question about the role of CamDocUK in control of the pandemic in Cameroon and also in other parts of the world. So that's a question I think you should answer as you round up as well.
Yes, certainly. That question was actually answered by Dr. Theodore Ngassa on the chat, so I wasn't sure whether I had to say it, but quite rightly, as you say, Dr. Nsutebu, CamDocUK is very actively engaging with our population, both here and in Cameroon. We have educational material, and we are also raising funds for personal protective equipment to fight this pandemic. We also have engaged with different hospitals and different NGOs. We have engaged with Médecins Sans Frontières, and some of our members are actually on standby to volunteer their services and their knowledge and skills to provide that practical help back in Cameroon should it be required. The terrain is very rocky. The terrain, as you know, in Cameroon is not the most easy to navigate. And at the moment we are under very stringent situations politically. So I think that we are I know that we are engaging with the powers that be as much as possible to help prevent this pandemic. We are also open all the time to receiving questions and queries and requests for of us for advocacy, and we have been doing so all the time. If you ring 111 and you can't get through, or you feel as though they're disregarding you because you are from Black and minority ethnic, because your name does not sound right, or because your accent does not sound right, please get in touch with us. Get in touch through the website and we will be back in touch with you. As I said, there is a button there where you can ask a question. Please do not suffer in silence. Our voice is here for you, and that is why we are engaging with yourselves at the moment to take this forward. I would like to thank every single person who has attended today from near and far, from Cameroon, from America, from UK. I'd like to thank all the CamDoc members who in the background have been working feverishly, and even other doctors. As I previously said, Dr. Brown Hilda Santo is one of those that I picked up, has been responding to questions. And I think that this just gives us it really is a testament of COVID-19 where we are coming together as a community, standing together, and although we have to socially distance, that does not mean that we are emotionally distant, and CamDocUK is right there for you. So I'd like to thank you all very much, and I hope that we can continue this discussion on a later date. Good night.
Good night, thank you.
Good night, thank you.
Good night, everyone.
Good night.
Thank you.